It's my pleasure to introduce Dr. Kevin Ng Wei Shan, who is Senior Medical Lecturer and Consultant Pediatric Anesthesiologist at the University of Malaya. Sorry. His love affair with anesthesiology began way back in 2008 in Kuching, Sarawak, where he was inspired to join the field after meeting the many wonderful anesthesiologists there who were able to tie the wonders of physiology to clinical practice. He's currently working to inspire a new generation of doctors and anesthesiologists from his university. His interests include enhanced recovery after surgery, ERAS, pediatric anesthesia, and patient blood management. Besides medicine, Dr. Kevin is passionate in enhancing the welfare of healthcare workers and is actively involved in various organizations in Malaysia which champion the cause. His talk today is getting brought up. His talk today is also a keynote address. Oops, sorry, is not a keynote address, but his talk today is entitled Optimizing Tissue Oxygenation and Supporting Patients' Tolerance of Anemia Perioperatively. Dr. Kevin. And I think you're in need of unmuting also,
yeah,
Doctor.
they muted me.
Got it. Got
Can you
it?
hear me now?
Yes, great.
Right, okay. Thank you, Professor Su, for the very kind words. I am also one of those anesthesiologists that fell into patient blood management because of the influence of Dr. Jamila and bringing me on and getting me involved. Since then, I've become more and more involved with all of this, and well, we are trying to get more and more people keener on patient blood management here in Malaysia. So today I've been tasked with speaking on pillar 3, which is optimizing tissue oxygenation and supporting patients' tolerance of anemia perioperatively. These are my learning objectives. We're going to be talking about recognizing the key components of oxygen delivery, apply the principles of optimization in the management of the perioperative patient, and then we're going to discuss how we're going to formulate care plans to optimize anemia tolerance. So essentially, oxygen delivery, balancing the supply and demand, and then mixing and matching. So this is the key, this will be the key formula that I would look at when I'm going to talk about optimizing oxygen delivery. So this is oxygen flux or the oxygen delivery formula, where delivery equals to the cardiac output times the amount of oxygen carried by hemoglobin added to the amount of oxygen that is dissolved in the blood. And if you look at this formula, it's very clear that the majority of oxygen will be carried by hemoglobin and very little is dissolved in the blood with a factor of only 0.003. The cardiac output plays a very big role in trying to deliver all of this oxygen to the tissues that are crying out for it many a times. So essentially what we have, after all the calculations that I've already input here, oxygen delivery is equivalent to about 11.5 mils per kg per minute. Now, if you look at that, that is actually above what is required by the body. The body at rest usually requires 3.5 to 4 mils per kg per minute. So that shows that actually we have quite a large room for us to play with, and the body is able to compensate to even greater heights if needed. So what can you modify looking at this formula? So we can modify the cardiac output. So we can modify the stroke volume, can modify the heart rate to increase the cardiac output. HB levels, we've heard Dr. Mandy's presentation before this about how we can optimize the hemoglobin levels. We can provide O2's oxygen supplementation, or I will talk a little bit about it, about hyperbaric oxygenation, and we can reduce demands, oxygen demands, which keeping everything calm for the patient. So we all are quite familiar with the definitions of anemia. I'm sure all of us here are familiar with that.
Hi, dear. How are you?
As a whole, perioperatively, I support the use of 13 grams and above as normal and less than 13 as anemic for both male and female patients. So what happens in anemia? There are some physiological changes that happen. The body reacts by increasing the cardiac output. It shunts blood to vital organs. In the renal, two things occur. Erythropoiesis is stimulated, and then in acute hemorrhages, the kidneys are stimulated to induce volume retention. So how are we going to optimize the patient's ability to tolerate anemia? So I've decided to divide it into three, where we optimize the delivery, we provide the breath of life, and then we reduce the demand. And these are the key points that are involved. So we go through it one by one. So the first thing that we can optimize is, of course, cardiac output. Now, cardiac output it can be something that we can do acutely, intraoperatively using pharmacological methods, or we could also improve the patient's cardiac output preoperatively by doing a proper assessment and prehabilitation. So like I said, intraoperatively, we're going to be looking at advanced hemodynamic monitoring and targeted titration, and followed by post-op. So preoperative assessment, what are we looking for? We're looking at comorbidities, anything that can affect cardiac function, like Dr. Mandy's case about the patient with a recent MI. Definitely the ability to raise the cardiac output will be less. Oxygen demand from the heart will be more. So these are things that need to be taken into account. So how do we correct this? So an early review in medical and anesthesia clinics is what we recommend to our surgeons. For complex cases, we actually tell the surgeons, if possible, to refer it to us before the surgical date is decided, so that we could review and optimize before we plan for the surgery. Ideally, it should be 4 to 6 weeks. For less urgent cases, could be longer. For more urgent cases, a minimum of 2 weeks is needed. So we can then assess the cardiovascular function. What can be done in the anesthesia clinic or a simple clinic itself? We can do effort tolerance through a careful history. We can do a simple ECG. We can do a 6-minute walk test, which has been shown to reflect quite closely with the patient's metabolic equivalents or METs. And of course, then we can refer to our friends, the cardiologists, for an echo, a stress test, and cardiopulmonary exercise testing, which is done by sports medicine physicians. We do lung function tests for those that are indicated, and putting all of it together, we then decide what is the best way that we can optimize. So how do we optimize? We do prehabilitation. We speak to either a periop physician or the sports medicine specialist for optimization. We refer to physiotherapy if needed, as planned by the periop or the sports medicine specialist. We do exercise, nutrition optimization, and of course, anemia correction if needed. Now, all of this requires planning and time. So this requires us to actually, like I said, plan ahead for our patients. So why should we do prehabilitation? It does reduce length of stay. There are a lot of studies that show better outcomes, but there are some that are equivocal. So meta-analysis at this moment is not conclusive due to the low level of evidence and heterogeneity. Right, so how do we do it? Like I said, structured exercise regimes. Our sports medicine consultants will then plan an exercise regime involving stretching, involving some light weights, to optimize the patient. We've done it with some success with colorectal patients, especially those with very high frailty scores. And we try to optimize their nutrition to build up their muscle bulk prior to going for surgery. Emotional support is very important. And of course, cessation of smoking and alcohol. So what's the objective of prehabilitation and intraoperative monitoring? Is to keep all systems running. Now, this is very essential. So how do we do it? So first thing, we do intraoperative targeted titration for fluids and volume. Now, the aim is to keep the patient euvolemic. Both ways have been shown to have bad outcomes. Either you are under volume or you're over volume, meaning that you are liberal or you are restrictive. Both have shown bad outcomes for perioperative patients. So it's very important that we keep the patient as close to euvolemia as possible. Volume replacement for blood loss is important to ensure cardiac output is maintained. We do this by using standard monitoring or advanced hemodynamic monitoring that I will see in the next slide, as well as strict IO assessment. So what is advanced hemodynamic monitoring? So it's the use of cardiac monitoring devices in patients with large fluid shifts. We frequently use the flow track, which requires an arterial line. The Acumen is a new system that is available that shows you more and more information that can be obtained. We do use some esophageal Dopplers, and of course, the gold standard would be the TEE. The gold standard overall, of course, is the PA catheter, but PA catheters have fallen out of favor recently, and we've switched more towards the pulse contour analysis. So what is pulse contour analysis? Is the analysis of the arterial line using that formula that I gave earlier on for the cardiac output. So these are just screen grabs from various things that we have. So the invasive, we can have the advanced hemodynamic. This is the flow track. This is the Acumens. Acumens has slightly more information in the sense that it could predict the patient's likelihood of going hypotensive 5 minutes before the actual hypotension occurs. As you can see, we have lots of information. We have the cardiac output, we have the cardiac index, we have the stroke volume variability. We can then adjust. Looking at all this, we are then trained to adjust it for the anesthetist, to adjust it to determine how much fluid the patient requires. Does this patient, like for example, in this case, the SVR, the systemic vascular resistance, is very low. It normally should be in the 1008s to 2002s. So we would require a vasopressor instead of pushing more fluids if the blood pressure was low. So these are things that we are looking at all the time. Now, for those that don't require invasive monitoring, we have something called a clear side finger cuff that can give us similar values and similar assessments without the need for an arterial line. You can just do it just with these two finger cuffs. We use this quite a bit when we are doing sick, I wouldn't say sick, but sick, not as sick patients that need monitoring, close monitoring without the need for an arterial line. This is from the esophageal Doppler and of course the TEE. Right. So we've covered how are we going to optimize the hemodynamics, the cardiac output. And of course, the next thing that we have to do to optimize is we cannot pull the trigger. Now, transfusion triggers are very important. We need to be able to assess our patients individually, but at the same time have some guidance in which how much hemoglobin should be targeted before you start transfusion. Now, in patients who refuse transfusion totally, then this is separate. But if patients who do allow for transfusion, we have to be careful not to pull the trigger without optimizing hemodynamics first, with fluids, with vasopressors, before we decide to transfuse. Now, these are the various transfusion triggers that has come about. The only thing that I would like to add in traumatic brain injury, there are 2 new trials that have come out in TRAIN and HEMOTION that are actually looking for, that's actually saying a liberal transfusion actually shows better outcomes compared to a restrictive, but all other groups actually show restrictive just as good as liberal. And when we say restrictive, essentially is you only transfuse if the hemoglobin is 7 or less. So this is from the consensus statement. So what should we do? We should discuss every transfusion decision. We should check hemoglobins before every transfusion. We should practice restrictive transfusion except in that certain conditions. And consent for OX should include risks of periop anemia and risk of transfusion, with discussion on steps that has been taken to address all of this. So things like cell saver, things like whether iron therapy is indicated, EPO, all should be discussed even in surgical consents. Now, why do we need our transfusion trigger? Essentially, we are trying to formulate a transfusion plan. So this is the formula to calculate our transfusion plan. For most of my patients, this is what we do. We calculate at what level would we require a transfusion and try as much as we can to avoid it. So a reminder, before every time that we think to pull the trigger, we stop, check, and review, and we only transfuse 1 pint at a time. So this is experimental, but this was mentioned in some of the notes that was given to me by BMSS about oxygen carriers. I have very little experience with this, but this is what I could gather. Hemoglobin-based oxygen carriers are harvested from human bovine hemoglobins. Hemopure has been reported quite a lot in South Africa. South Africa is licensed for human use. In the US, it's still experimental. Perfluorocarbons, according to UpToDate, it's actually quite widely used. 35,000 transfusions supposedly in Russia. So these are quite interesting things, but like I said, very little experience on my part. So post-operatively targeted transfusion. Now, how often do we see this? IV drip 2.5 liters per day, normal saline, alternate D5. Is this required? A lot of times we are diluting our patients, or it's insufficient to meet the demands. Drain losses are often overlooked. NG, CBD, drains, all are forgotten about, and the patient always tends to end up hypovolemic. And then if the HB is a little bit low, instead of correcting the volume because of the that has caused the tachycardia, they transfuse blood. So we have to be very, very aware of that. So going on to my next one, breath of life, we're looking at all of this. The most practical point is propping up your patient. As you can see, FRC is our main oxygen supply. This is what we need. If you're propped up or you're sitting, your FRC improves, your oxygenation will improve. Oxygen supplementation as required. Teach your patients deep breathing exercises prior to surgery. So this is what we do. Post-operatively, oxygen demands can increase. Ventilation is impaired because of atelectasis, pain, or hypothermia. Oxygen supplementation is indicated if we suspect delivery is low. So what we normally would advise for is if the patient is a little bit on the anemic, we should always provide oxygen supplementation. So how much oxygen supplementation? We usually give 5 liters per minute via Hudson mask, going up to 40% oxygen if required. Now, the patient's ventilated. Now, this is one of the interesting studies that I saw in severe anemia. This is case studies that they've done. Hyperbaric oxygenation, oxygen chambers in severely anemic patients. Now, for example, the patient that Dr. Mandy was giving, where the HB of 3.8, if we are trying to buy time for us to build up using IV iron, hyperbaric oxygen supplementation could have helped the patient as well. So effectively, remember what I said about the dissolved oxygen? Now, at hyperbaric oxygenation, where we give oxygenations above atmospheric pressures, what we can do is the normal dissolved oxygen is only about 3 mils per kilo. So we can actually bring that up, as you can see, almost 160 times, which is actually sufficient to meet all our oxygen demands if we leave our patients in the hyperbaric chamber for about 1 to 2 hours per day during that period. So this study by Fener et al. Showed that at a HB of 5.6 at 100% oxygen, the heart rate was similar if to patients who were transfused to 8.9 at breathing 21% oxygen. So that really shows a difference, that if you can provide higher oxygen supplies, you can actually bring down the heart rates and improve the hemodynamics. So lastly, reducing demand. So what are we going to do? We have to keep our patients comfortable. Now, I'm going to talk about poorly controlled postoperative pain. So what happens? If postoperative pain is poorly controlled, you're going to get a lot of changes in the body. And the most important is the cardiovascular changes, where there's an increased oxygen demands because of the tachycardia, because of discomfort. So what can we do? We manage the pain, provide good analgesia. We make sure that the patient is very comfortable. Regional anesthesias and continuous wound infiltration is very effective, however, still very expensive. In Australia, when I did my subspecialty training, was really good because we could use the continuous wound infiltrations to great effect. But here in Malaysia, again, it's very expensive. Now, these are other things that I like to show. PONV is post-operative nausea and vomiting occurs quite frequently in operative patients. Vomiting, the retching all can cause an increase in oxygen demands. Being cold or being too hot also can increase oxygen demands. And these are things that you can control simply pharmacologically or by warming or cooling the patient. Now, I put this picture here because one of my patients, after cardiac surgery, when he woke up, he told me, I felt like I was in bed with snakes because of all the tubes that's around him. And he got very, very anxious and agitated because of it. And these are pediatric patients. So it's really understandable that with all the tubes around and you're not aware, could feel very uncomfortable. And we should take that into account. Now, the environment, a quiet environment as patient awakens is important. Now, if everything is noisy and busy, you have just awakened and suddenly you hear all these noises, you suddenly will become anxious and agitated. And this, again, can increase the oxygen demands. A lot of times we try for pediatrics, we bring in the parents to try and calm the patient. So this helps as well. It should not be like the night markets of Malaysia where it's so noisy and everybody's speaking at the top of their voices. So what do we want? Happy patients, waking up pain-free and comfortable. So how do we formulate our plans? So this is what we do in pre-op, intra-op, and post-op. We pick and choose as per our patient. We've got to decide what is best and what is needed for our patients to meet our desired target. Essentially, maintaining the hemodynamics, controlling the pain, keeping the patient comfortable, and euvolemic. So in conclusion, how low can you go? There is no definite answer. Everything needs to be individualized. We need to know our patients, discuss with our patients what are our options. There is no one transfusion trigger. The fitter the patient, the lower you can go. So prehabilitation is important. If you have hemodynamic monitoring, you can go lower and lower because you can optimize the cardiac outputs better. So remember the basics for improving oxygenation, positioning, analgesia, temperature, post-op nausea and vomitings. Comfort is, of course, the key. So this is my conclusion, the same thing that I've been saying again and again. Optimize our cardiac output, provide a transfusion plan, motivate the patient, provide an analgesia plan preoperatively, intra-op, hemodynamic monitorings, maintain euvolemia, stop, check, and review for every time you think of pulling the trigger, maintain euvolemia post-op, prop up the patients, and keep the patient comfortable. So I think that's the end of my talk. Thank you very much for having me. And I hope you've all picked up something from my sharing. Thank you very much.